after next week will all be on test 2. So, and that'll be on a Wednesday instead of a Monday, just so that when y'all start OB, it's fresh. You don't have any other content on your test except for OB. All right, we're going to just discuss infection. I just kind of go over a little bit of information as far as stuff from your pathogens class. Back in the past, you don't really need to know these first few slides for your test per se. You just need to know if they mention this stuff on your floors, you know what they're talking about. So an acute infection, we may think like an acute UTI. So they have symptoms, we get treatment, and it resolves within a few days. Maybe into like a week or so, but it doesn't really go longer than that. Chronic, we think of maybe a chronic UTI, maybe it lasts more than 12 weeks. Maybe it's ongoing. So we've all had those patients that have had chronic infections. Localized, what's localized mean? Limited to a specific area or site. Disseminated means it's spreading. Systemic means it's affecting our body as a whole. Sepsis is the presence of a pathogen within your blood. So now it's in your bloodstream. Then we have epidemic and pandemic. So epidemic is within a community, and then pandemic is what we're living through right now currently with COVID. When I started teaching in 2019, we didn't have COVID, so I would kind of look through history and think of like the flu, or we would talk about the movie Contagion, because that was kind of the only example I had of a really good pandemic. But now we have COVID. So what did we see when COVID hit? What happened to the whole world?
Panic.
It stopped, right? It felt, to me, I remember thinking when we had to wear masks, how weird it was. We had to wait in line to go to the grocery store. They had to count us. I remember thinking, what will it feel like without a mask on? And now, we don't have masks. Now I'm like, okay, we're back to normal. I thought it would take forever to get used to not, seeing people in masks, and we still do, but it's different. Sporting events, they shut down March Madness that year. They, the football stadiums, when it came to the fall, there was no people in the stadiums. All the games were shut down. So it just felt very weird. So here we can kind of see, when COVID first hit, but then in the modern day, but then in the past, we can see, wear a mask or go to jail. This was stuff that happened when the flu hit. So back in the day. So they kind of had those same things with the requirements. Microorganisms. Why do we need to know the different types? Why? What is the primary reason we have to know this?
In order to combat.
Yes. We can't give, if somebody comes in with herpes, can we give them an antibiotic? No. There's reasons why we have to know this. It isn't just to make everybody's life crazy. It's because we really need to know what's going on. This is why we have issues with antibiotic and people
Overprescribing.
Yes, overprescribing. Looking for the word. So people are getting antibiotics like crazy. My grandparents are awful. I love my grandparents. They're awful about this. They get a sniffle. As soon as they get a sniffle, they call their doctor and say, I need my Omnicef refilled. And guess what that doctor does?
Refills it.
Refills it, gives them three refills.
Oh my
Okay?
God.
This is why we have issues today. Listen, I got yelled at by my little old women when they come in and say, I need my antibiotic, and I say, when did your symptoms start? And they say, well, yesterday, but I need to get on it now. And I'm like, that's not how this works. And they would yell at me. I got cussed out. But this is what has happened. People have just said, just get her out of my office, just give her what she wants. And now we have an issue with infection. Public health concerns. We have health acquired, which is hospital, and then we have community acquired. So the treatment is often different, especially when we talk about MRSA, and you'll see why, because of it causes different things. You don't need to know table 25-1. Don't do that. Don't forget that. Infection process. So you probably remember about the pathogen, your susceptible host, portal of entry, portal of exit, all those things. Again, this part is not on the test. It's just we have to know these things in order to, we have to know how to treat it. I mean, how do we know COVID spreads? That's why we wear masks. That's why we get the vaccine. So again, we have to know these things to try to eliminate it. Endotoxins, exotoxins, you probably kind of remember from pathophys. So these are just, some of them go with gram negative, some of them go with the gram positive and negative, but it's just the kind of reactions we see, like what causes those reactions in these people. Consequences of infections. What if we leave an infection untreated? What can it cause? It can cause sepsis in our body. If our immune system cannot combat it by itself, then and we have to help, but if we do not, it overwhelms our immune system. So then our entire body starts to try to compensate. So inflammation can cause the vascular system. What happens? Does it shift the fluid from intravascular? You remember that crazy stuff in physiology where it shifts from intravascular to extravascular? Then we get what when it shifts to that extravascular space? You have ascites, you have that swelling going on with those patients. With that shift from intravascular to extravascular, now we have what in our bloodstream? Do we have a good cardiac output? Or should no. We have a low cardiac output. So then that tells our brain that says, oh my goodness, we're running out of blood, we need to do something. So then our vascular system starts to constrict, right? To shift that blood to the essential organs. What's our essential organs? Lungs, heart, right. So there's 3 essential organs. So then that gets that blood supply. The renal system, it will start to vasodilate. So when this happens, it's trying to keep all that fluid inside of us to help that cardiac output. So when it keeps all that fluid, what do we see with urinary output? Increase or decrease? Decrease. What is a normal urinary output? We should know that 30 cc's an hour. So within 2 hours, if we only have, say, 30, is that good or bad? It's bad, so then we need to do something about it. So those are just things that, we have to remember. Our respiratory system, well, oftentimes it gets notified because our tissue perfusion is now ineffective because of low cardiac output. So then it tries to compensate. Oftentimes we then have hypercapnia due to the respiratory trying to compensate. What happens when all these things, nothing works? Multi-system organ failure. Now our organs are not getting the blood flow we need. Can we die from that? Yes. So that's why it is very important to see this stuff early on, to recognize it early on. So that's why input-output, we should really be watching it with patients. And oftentimes when we go, I hear students say, they're supposed to have input-output, monitoring, and I don't see anything on the chart. That's a bad thing, right? Because then we're not recognizing, something really goes wrong. We're past that at this point with these patients. Population-based. So who's at risk for infections? Everyone who's our most vulnerable. Yes. The elderly and the very young, or those with other factors, risk factors. Individualized base, so immunodeficiency. So we'll talk about this too next Wednesday when we talk about HIV. Cancer, we just talked about cancer and how they are immunodeficient. Chronic diseases, and then we have our environment, crowded living situations, unsanitary conditions. So all these things come into play. When I talk about, I often bring up home health a lot because I've been into a lot of homes that are very unsanitary. And it's all about education. And even if they have wound care, how do we teach them? And it's not to embarrass them. And I always bring that up. I say, I'm not trying to embarrass you. I'm not trying to make you feel bad, because sometimes people are like, oh my gosh, I'm so sorry. And I say, don't have to apologize to me. I know how it is. But we really have to educate on, cleanliness, especially when they have wounds or so forth. Your assessment. So exposures, past medical history. Examination findings, what will we see if they have infections?
What else?
What's something we walk in, we can see on the patient. We can do with the patient, right then and there in the fever. Fever. What else? Maybe they're feeling a little chill. You know, those kinds of things are things we can recognize with these patients. Diagnostic tests, white counts, obviously, when they have those cultures. When I talked last week with the different types of leukemia, and I brought in those basophils, eosinophils, those are the differential counts with the white cells, and those are important because that can kind of, if we are treating something that we think is a bacterial infection, they're not getting any better. So then the physician's like, I want to go ahead and run a differential count because I need to figure out what's really causing it. But we can see maybe it's fungal, maybe it's something fungal, and we are completely treating it incorrectly. So they can tell that with those differential counts because the eosinophils, basophils will be increased with maybe parasitic as opposed to the bacterial virals with which increases maybe the neutrophils. ESR and the C-reactive protein, do you know what those two labs do? When we draw those two specific labs, it just tells us that there's inflammation in the body. So you definitely want to know ESR, CRP. Again, primary prevention, secondary prevention. I'm not going to go through all of this because we already know primary prevention to the spread of infection is what? Hand washing. Our number one is hand washing. And we also should be educating our family members as well when they're coming in or they have to take care of the patient. They really need to also understand those techniques of what is acceptable when caring for a patient with an infection. Collaborative interventions, obviously, are treatment, antibiotics, antivirals, fluid nutrition. Precautions. I will always tell you what type of oh my gosh, about to provocative. It is not provocative. Precaution to utilize. That is not in my mind, don't worry. I don't know why I said that.
What was the word you used after that?
Precaution. You should be precautions. Provocative.
Provocative precautions.
So, airborne droplets, your contact. I will always tell you what infections lie in each one. You guys don't need to read about that. You don't need to figure that out. The biggest difference is in the hospital, so droplet precautions, and this is different. Okay, so when testing purposes, if you see this, and I do not put this on your test ticket, and I will not do this because it can confuse you. However, in an NCLEX setting, what is a droplet precaution? What are the two things that you utilize with droplet precautions? Gloves, masks. It does not include gowns. Do we wear those in the hospitals? Yes, because we could come in contact with that. So just to know, I mean, that can get a little, hairy. So I don't include that stuff. You just need to know, like airborne. What would we do for a patient in an airborne? Right. What do we got to do?
Reverse ventilation.
Yeah, the negative pressure, right? What about our mask? N95. We can go with the surgical mask. We got to have more protection. But they will also include your gowns, your gloves, everything like that, right? But as far as airborne, what it is, droplet contact, so forth. Okay? Neutropenic precautions. What do? We've talked about this with cancer, right? So are we protecting ourselves? No, we're protecting
the patient.
Yeah, because if we're seeing somebody with all these MRSA, VREs, all these things, and we go in to our patient that has cancer, on neutropenic precautions, we don't want to drag all that.
We're going to take them a big bouquet of fresh flowers and a big bowl of fresh fruit.
Right. Yeah, we avoid that. MRSA. So what is MRSA? I remember being in school being, gosh, I don't know, get everything. I don't want to have MRSA. And everybody said, you probably already have MRSA. And so MRSA is a staph infection, right? So staph, does it commonly reside on our skin? Yes, it does. Some people are colonized with it. It means it doesn't affect them at all, but they can carry it. That's why we have to, be very cautious with our patients when we're performing close contact and care with them because we can spread it as well. So again, we need to know the difference with MRSA as far as hospital-acquired versus the community-acquired because it is treated differently. How does MRSA enter our skin? Right. So that is one of the primary reasons that patients often get infected with MRSA. Again, your types of MRSA, your hospital versus community. So community is definitely maybe these healthy people that are living in their house or their home. Maybe a young child gets infected. We don't know why or where. Probably at daycare. So those are things that we can tell with the community hospital is they're in the hospital and now they get MRSA. You know, a lot of IV sites, their joint replacements, their heart valves. Those things can cause this infection to spread with these patients or cause them to get these infections. So is there a breakdown possibly with sterile technique? Absolutely. So that's why we really have to monitor. And if somebody breaks sterile technique, we step in and we tell them and we notify them. Types of MRSA in management real quick. We had a doctor when I was in nursing school and he had a long beard. Really not beard, but really long. And he was doing an abdominal dressing change on a patient. So he was in there and he had just went to another patient's room, never washed his hands, got his gloves on, went in there, was over top, and I kid you not, his beard was in, like, on the wind. Grossed me out completely. But then the nursing instructor, she did step in and was like, hey, you need to put something on you're all in her wound and your beard's in her wound. So yeah, you need to step in with those things, be a patient advocate. So how do we manage the different types of MRSA? So your hospital acquired, you're going to see different maybe treatments, maybe how they bathe their patients are a little different. Our treatment is definitely different. So we see the IV bank, oral Zyvox, IV Teflaro. The Zyvox and Teflaro are very expensive. So you probably more so see the IV bank unless they may be allergic to it. So they may do the other ones if you see that. IV bank, what do we know we have to do as we monitor this medication? We have to draw a trough, okay? The range that we like to keep these patients is between 10 and 20. They should draw the trough prior to the fourth dose. So 30 minutes prior to the fourth dose. What if our bank level is at 35? What do you think we should do? What do you think the physician's going to do?
I think they're probably going to still give it.
They'll give it, but what will they do to the dose?
Usually.
Lower.
Yes.
You said 30 minutes
Fourth dose. Now that gold standard treatment, you'll probably see people do it before the third dose, but you really have to do it before the fourth dose. You want a few of those rounds in before you draw that trough. And they'll continue to monitor it once they have that first trough. Some side effects of bank, black tarry stools, abdominal pain. Now with community-acquired MRSA, this is really spread in the dormitories, maybe in the military, the barracks. Prevention, obviously, hand hygiene, avoiding large crowds, watching, being around those infections without gloves on. Treatment, your aminocycline, doxycycline. Can we give those to pregnant women? No. What should we educate about doxycycline, aminocycline? What about the sun? Stay out of it. If you're going to be in it, you better lather the sunscreen on. Bactrim, we also give for community acquired. So your skin infection. Okay, so it is a common skin problem. Again, you get that break in the skin. That's when the staph kind of migrates to it and gets deep within that wound. When you do a wound culture, it isn't just getting that top little layer. You want to get deep because to get a good specimen, I got to go deep into that wound. Patients that have these skin infections, if they're home, what are things that we should tell them? What's some information we should tell them? Say it's on their leg.
Keep it covered.
Keep it covered. What else? What else? Because patients don't like to keep it covered because they think air is great for everything, right? They hear that all the time. Just letting air out as they're dripping down to their kitchen floor. Not kidding. So what would we tell them? What about their bedding? They're sleeping with their wife, their husband, spouse, whoever. Their wife's all up in it. I'm not trying to I've been there. That's why I tell you guys, educating them. Can we just wash it? Well, I don't like to wash my stuff in warm, hot water because it shrinks everything.
Do it anyways.
Do it, right? Sanitize that thing. Put it on the hottest hot water you can get. Their dressing. Do we want it where the cats are all jumping? No. We want them to let's clean out somewhere. And this is what I do with patients. Let's find somewhere that we can put all the stuff that's not in your way, and we'll just open something, and I'll say, can we put it here? They're like, yeah, sure. And I'm like, okay. So we'll clean it out real nice and put everything in there just because it's nice and clean. Because my cats would be all over that stuff. Oh, something new. Let me get up on it and put something on it. So that's why we have to put that stuff away. What about diet? Is diet important for wounds? Yeah. What type of diet? I mean, obviously, we got to watch with other health concerns, because some people can't have a lot of protein. But peanut butter, things like that, beans are good sources of proteins. Always know your good sources of proteins because we can always educate those things with these patients. CRE. So carbapenem-resistant bacteria, okay? This is often referred to as superbugs because what these infections do, so it commonly can be E. coli, but what happens with this certain type of E. coli is it has these enzymes that actually breaks down the carbapenem antibiotics. So then we can't use these great antibiotics because these enzymes can just shred it, and it's not effective. So there's really not a lot we can do at that point when we cannot. If we need these strong antibiotics and we do not have them, I mean, they can try bank, they can try other things, but it may not work. Okay, so this is kind of one that they get really scared about in the hospitals, and we really have to be very cautious with these patients, actually abiding by the contact. So the contact room, you put on the gloves, you put on. I am very much a stickler when it comes to make sure you have, if it's there, you put it on. Don't just go in there and take in their vital signs and stuff like that because this stuff can spread quickly to other patients. And if you're going in helping another person in another patient's room, then you may spread that, and you don't want to be that person. Chlorhexidine bathing for these patients, but a lot of times it has a lot to do with abdominal infections. So making sure you wash your hands. You can also do your alcohol-based alcohol hand sanitizer, but really just preventing the spread of this bacteria. VRE, so pretty much another bacteria that has become vancomycin resistant. So then again, this may be somebody that we use maybe the carbapenem as opposed to the vancomycin because now we can use that. I don't really ask you a lot of questions on the CRE or the VRE, but you just have to know it when you're in the hospitals that you need to abide by those contact rules and precautions. Inadequate antimicrobial therapy. Why do we have an issue today? Obviously, non-compliance, non-adherence. So patients that may just forget their medication. So they just forget. Or maybe somebody that just doesn't care, they don't want to take it. Okay, there is a difference. Somebody that literally just really does forget to take their medications. Okay, it's not, an issue, we can actually help these people. Because what can we tell them to do? If they have a cell phone, what can we tell them to do? Put them in their reminders. That's what I tell young girls. I used to do that when I would give out birth control. They say, oh my goodness, how am I ever going to remember this? I'm like, put a reminder on your phone, take it at bedtime. If you know you're going to be in that same bed every night, then you need to have, or carry them with you. So you have them and you can take them. Non-adherence may be more of the patient that they just don't really care to take their medication. But we really need to educate when, if they start this regimen, they need to complete it, because if they don't, then what happens? Yes, it comes back. And then we become resistant to these medications. So resistance is caused by these issues. History. So obviously, again, we want to know any exposures, travels, who they've been around, if they've been around any type of infection. If we start seeing signs of infection, we want to know where it came from. You remember COVID, it got to the point where you couldn't travel out of state. Or, they still ask you, have you traveled in the past 2 weeks? Why do they need to know that? Because they want to know where you went if they have high numbers. Physical assessment, again, your pain, redness, swelling, fever, all those things we're going to be looking at for these patients. I included psychosocial assessment because a lot of, there's a stigma. There's always stigmas with infections. So MRSA, they have MRSA around them. But, you really have to educate patients and families about this and just say, hey, it'll close up, it'll be fine. People just literally don't want to touch anybody with it, but we just really have to educate that. The patients are probably going to be embarrassed anyways. They just got to educate the family. Laboratory. Again, your CBCs, your cultures, ESR, C-reactive protein, see that inflammation in the body. We may even look at the total protein. If somebody's not, their wounds really aren't healing. Imaging. They may image in the sinuses, which we'll talk about when we talk about meningitis. Treatment for managing fever. Your home care are already included some things that we can do in the home and education. Include those precautions. And with resources, some patients may not really have anybody in the home to help them with their dressings. And yes, they can have home health, but this is why I educate you guys on home health, because you want to know, because it's not in the hospital, sometimes they think home health is just caregiving. It is not. The medical side of it is not just, helping you with your wound every day and doing those things. Home health goes in 2 or 3 times a week, and then it decreases because of Medicare. We cannot go in all the time. So then we would explain the difference between a caregiver and home health, because home health is short-term, caregiver would be more long-term for these patients. RSV. So respiratory syncytial virus. This spreads like wildfire in daycares. Both my children have had this, and it can be deadly to young kids. So they appear maybe like they have had just a common cold, runny nose, decreased appetite because of all that congestion. They can't really eat. Coughing, sneezing, fevers. It can be low grade, but then it kind of gets higher. Irritability because they cannot breathe. You see those retractions. What are retractions? Yeah. So when they're sucking in and really trying to breathe. What happens is this virus goes straight to the lungs. And it causes all that congestion. It can cause pneumonia, it can cause bronchiolitis. It can last up to 1 to 4 weeks. Usually between day 3 and 8 is when they are very contagious. That's why these kids really should be out of daycare for a long, long time. It is common in the winter and spring months, so right now is a great time for RSV to start showing up. For most adults, so if I get RSV from my child, it would look like a cold, like sniffles. For my daughter who's 8, it probably would look like a cold and sniffles. For a young baby to a year old, it's a lot worse than that. They have to be hospitalized. A lot of them have to get breathing treatment. May have a lot of wheezes and crackles. Is it contagious? Yes. These patients will be in droplet rooms. You will see, I have seen in so many different books, contact precautions, droplet precautions. Just add them, okay? Droplet contact, I don't care. You just need to be gowned up. You need to have a mask on. Because what happens, especially in daycares, when you have a child that's sick, and we're like, and now we're wearing masks, so we're keeping ourselves safe. But if I'm picking up a child that has RSV and he's not all over me, then I go pick up another baby. What am I doing? I'm transferring that to that other child. What we really have to be cautious about is children with congenital heart or lung diseases. They can get very, very sick. Children with cancer, even adults with compromised immune systems, because it can make an adult very sick as well. Ribavirin, R-I-B-A-V-I-R-I-N, ribavirin is the only medication for treatment. However, you really only give it when benefits outweigh risk. This is really only given for a child that is put in the hospital, that is very, very sick, or has those compromised immune systems. It's really not given. Both my kids have been hospitalized for this, and neither one was given ribavirin. That's really given just on who they think needs it the most. Okay. R-I-B-A-V-I-R-I-N. Prevention. This is always a fun one with my kids. I'm like, cough in your arm. Sneezing, coughing, obviously the best thing is to have tissues around for your child. Sanitizing everything, disinfecting toys. So, all kids like to wipe their snot and go on playing with their toys if you've ever been in daycares. So that's why it's really important to really do a clean, especially in the winter, spring months, because of the stuff spreading. Palivizumab is a medication given for prophylactic treatment. What's prophylactic? Preventive. So this is only given to high-risk infants. This is not given to every child in daycare. This is only given to children with compromised immune systems. We obviously educate families on not smoking around their children because, obviously we don't want that included also when you're sick. Washing your hands, keeping, your child away from other children at the time when they have RSV. Treatment, rest, fluids. They may have to have those bronchodilators. They may even have to have breathing treatments that have the steroids also in them. They may have to have O2. What do we need to do? Do we just slap O2 on a child with RSV? No. We have to monitor their stats. If their stats are good, we don't just give them, just because it can be difficult to breathe, but we just don't give O2 just to every child. IV fluids, because it can break up. A lot of times children, the best thing we can tell families is what? Getting fluid in them. We also may tell them to hold the milk, even that's very hard for young kids because they love milk. Because why? Makes it thicker. If you can ever think of a time when you felt sick, maybe nobody likes milk, but if you've ever been sick and you try to drink milk and then it gets all like real thick and you can't swallow, it really causes a lot of issues with babies. Things that we can educate families on is maybe getting their little bulb syringe and kind of getting in there and getting all that mucus out before they're feeding, because then we can get that stuff out of their mouth before they eat the milk. Yeah. Oh yeah, I've done it to my son too. My son is good, but my son. Antiviral medications, again, that would be the children that could receive the ribavirin. Not saying that they always do, but they can. Something that I read last year in a study said to actually use humidifiers, if you have young kids, humidifiers in a child's room continuously through the winter and spring months, because it reduces flu, RSV, is so big salve. You know, they always the old tells us to put it on their feet, put little socks on, and that helps them to stop coughing. One thing that you can also do is hold the baby in a shower, and people actually put big salve in like ice containers and fill it up with water. And then what you can do is break it, and when you put it into the shower, it causes a steam, and the smell kind of opens up their lungs. So that's also teaching you can do. Obviously, if they have a fever, Tylenol. So how do we test? You know, those nice COVID tests? Pretty much the same thing. They go up the nose, they swab it, and then they see if they have RSV. Usually takes about a full day until you really know. But usually they just tell you to keep them home, give them fluids, and anything to help them with their breathing. Let's get through this. So meningitis, you have your inflammation of the meninges of the brain and spinal cord. You will now see why, like, all the signs and symptoms go with meningitis. It can be caused due to bacterial, viral, fungal. Medications can also cause meningitis. Nice thing about medications is if we can link it back to a medication, we take them off the medication within a few days or better. So that's a nice thing about meningitis caused by medication. However, bacterial, fungal, viral is a different story. So organisms are responsible for entering the CNS. How do they enter the CNS is the question. So what are some ways that we have direct routes of entry? About trauma. Somebody's in a car wreck. Trauma, and it can even be surgical procedures. But it's at the certain sites that are closely related to the CNS. Okay, so maybe your ear, your sinus cavity, things like that. Infections are linked to otitis media, sinusitis, tooth abscesses. With the immunocompromised patient, the infections do spread quicker, so it's important that we recognize it right away to prevent those serious complications. Viral meningitis is also referred to as aseptic meningitis. Common viral organisms, your herpes, varicella, zoster, HIV. Aseptic meningitis. The severity depends on what's causing it. What is it?
You say virus is cold.
Right. It just depends on what virus, though. It most often affects children under the age of 5. When it affects children, it can be more difficult to treat. We have Cryptococcus neoforms, which you will hear again when we talk about HIV, because this is commonly seen with patients that actually revert to AIDS. It is a fungal infection that has caused meningitis. It mimics bacterial meningitis. However, this is not, you don't need precautions with the fungal. You can't spread it. Bacterial can be caused by listeria. So a lot of our pregnant women that, we always really teach a lot about not eating, your, all those, what am I thinking?
Lunch meat.
Your meat, yes, lunch meat. Oh my gosh, what is wrong with me today? Your lunch meats, anything like that, unpasteurized milk, cheeses, we got to really be cautious about because it can cause meningitis. Even in us, but pregnant women, their immune system is compromised. So the one Neisseria meningitidis is actually the meningitis that is also known as meningococcal meningitis. Oh, that's a Monday. So is this contagious? When we teach all of our young people that are getting ready to go live in dorms at their college, yes, that's why we have the vaccines for this particular one. Okay? So these patients, if we even think they have meningitis, until we rule this out, every patient should be in a precautionary room. Droplets. Where do outbreaks occur? I said dormitories. Prison, yeah. Military, yes. Crowded living areas. So patients that may be more at risk are those under the age of 20. Those
But
that
in
skip
cultures where there are several generations, culture, they're all crammed into.
right. Like all my patients in Illinois where they all live together, that would be a huge risk.
You said under
Under 20 are more at risk, yeah. And those that skip the vaccine have never had the vaccine. Colleges now, I mean, they're pretty on it. You have to have those vaccines before you can even go into a dorm, stay in the dorm. You have to have them. Your symptoms, so headache, altered mental status, phono and photophobia. So what's that mean? Phono and photophobia.
sounds and light.
Sounds and light. So this right here probably will give them a headache if they stood in front of that light. It really give them a headache. Loud noises, and you may not even think you're being loud to them, but it is. They're very sensitive to noise. They may have neck stiffness. They may say they see a rash. What it is petechia. What's petechia?
It's where the blood is. It's your blood is thin and it comes up.
So what happens with meningococcal meningitis is when it affects our bloodstream, it actually degrades the blood vessels, which causes the bleeding. So that's what we see with these patients. So if we recognize that, then we know, there's some issues going on with the patient, and it's affecting their bloodstream. Complications, if we end up really not recognizing this, and we don't treat them correctly, brain damage, gait concerns, seizures, renal failure, shock. With babies, when they have meningitis, when they cry, because obviously they're going to be crying, right? I mean, their head hurts, they don't know why. Babies, they don't understand things. So when they're crying, their fontanelle will actually bulge. So that's what we see with our children. Shock, death, gait concerns, brain damage. I wish I had an assessment table in here because I could actually show you these. So when you possibly think this could be happening with your patients, you would lay them flat on a bed. You would do the kerning sign. The kerning sign is just what it shows here. You have them lay straight down. You pull one leg up to a 90 degree, and you bring the leg up. As you bring the leg up, if it elicits pain, that means that that's a positive sign. The Rudensi sign is a little different. You have them lay flat. You can stand at the side or head of the bed, whatever. But you bring their head up, and as you pull their head up, their knees flex this way towards it because they're trying to relieve those meninges of that pain. So this would also be a positive sign. So those are things that you could do in an ER if you have a patient walking in and you suspect it could be meningitis. A lot of information here. Okay. Neuro and vascular assessments you have to do with these patients. Inflammation can cause your brain to actually let down ADH, which is what antidiuretic hormone, what to do. went over it with us, all your oncologic stuff, your emergency. What is it? You retain fluid. Okay, so if we retain fluid, that can cause swelling in our brain, okay? So cranial nerve testing is very important with these patients because there's one cranial nerve specifically that tests the ability to move the eyes laterally, okay? So if a patient has the inability to move the eyes laterally, we think that they could have hydrocephalus, which is that swelling, okay? Cranial nerve 6. So if they have the inability to move the eyes laterally, and we think that they may have some hydrocephalus going on, what's that put them at risk for? What about their intracranial regulation? Their pressure, okay? So the pressure of the brain may be increased, so we would really have to determine that. And we'll talk about why it's so important for that we monitor that here in a second when we talk about tests. And we have ADH, what's that do to our sodium levels? Decrease them. So if we have a decreased sodium level, what are we at risk for? So coma, confusion, those are things, that's why we really have to watch those lab values with these patients. With inflammation, it can also cause our body to have clotting. Okay, that's why vascular assessments are also thrown in there because when we clot, sometimes it's in these small vessels of the hands and feet. So if you are assessing patients and they're complaining of a new onset of pain in their hands or their feet, you don't just say, oh, it'll be fine. I mean, what are some assessments we do to check their vasculature? Yeah, capillary tap, what about your pulses? You look, you see if there's any redness, tenderness at the site. Those are all things that you want to do. Because if you just call a doctor and say, hey, patient has some hand pain, can I give him a he's going to say, well, what is your assessment? I don't know. Just rate it at 5 out of 10. I don't know. Don't do that. You're going to have to assess them before you make those calls. If we don't take really care of those clotting in the beginning, then it can lead to DIC, which we already know what DIC is. So then we have clotting throughout the body, and we also have bleeding. Now, Ms. Hackney will talk to you guys about a late stage or a late sign of ICP, which is called Cushing's triad. So definitely be understanding of that when she goes over that on Wednesday. Vaccine age, they typically see them give, I think, between the ages of like 11 and 12. Booster usually is at 16. They may have changed it by now, but that's what it used to be. So these patients are at risk for a lot. Not only now we see why they have a headache and things like that, but we have a lot to monitor with these patients. Testing. We're looking at the CSF fluid. CSF fluid is usually a nice clear color. When it's bacterial infections, oftentimes it'll be like a cloudy, turbid color. They also look at, which I'm not going to have testing on this portion, but they look at the sugars in it, the protein levels, because if those are increased or decreased, then they can tell if it's viral versus bacterial or fungal. That's why we have to test the CSF. If you see here, it's delayed, then you give broad spectrum antibiotics. And I'm going to tell you, the only time you do that, the only time you do that is if we have to delay a lumbar puncture. Why would we have to delay a lumbar puncture? If your ICP is elevated, you cannot send a patient to do a lumbar puncture. And if you, as a nurse, miss that sign and send them for a lumbar puncture, it could cause brain herniation. Because what happens is as soon as they go to do the lumbar puncture, it causes, it's almost like pulling a plug for that CSF, and it pulls it down, and then the brainstem and everything pulls down, and it herniates it. So this is very important and why we have to assess these patients. Doing all those cranial nerve, now you know why cranial nerves, you're like, why would I ever do that to a patient? Now you know. These are things that we have to assess for. We may even do blood cultures if it has to be delayed because we can see, what else is going on there. But then that's when, after we would do the cultures, that's when we could give the broad spectrum antibiotic. This is really neat to read about because they use kind of like electrical stimulation when they draw the CSF to see which way it goes or how it fluctuates, and that's how they can tell if it's a bacterial or viral source. But CBC, again, we may see that elevated white count. X-rays, because they may be looking at, the sinus cavities and things like that, trying to figure out where it, maybe what happened to the patient or how they got it. They go on to do surgery. So other interventions, obviously hand hygiene when you're going into their rooms, especially if you do not know yet if it is bacterial meningitis, then obviously you need to be gowning up, okay? Monitoring, there's neuro and vascular assessments, your cranial nerve assessments. We definitely want to educate because if patients, if they're in that dorm with a lot of students and they have meningococcal meningitis, then we probably need to be contacting a lot of those people that were in close proximity with the student because they would also need prophylactic treatment. So prophylaxis, obviously with anybody that has a bacterial infection, they usually will get this treatment for 2 weeks if they have meningococcal meningitis. Rocephin is always a good choice for the medication. You guys will learn more about mannitol on Wednesday, but if they do have increased ICP, then you may see mannitol given to the patient. An anti-epileptic drug may be given only if we see signs of the ICP. If their sodium levels decreasing, that may also be, we want to prevent that. Steroids can also be given just for hydrocephalus, maybe if they don't have ICP, but it can help also with that swelling. So these are some common treatments for meningitis. So you have your antibiotics, your antivirals, your antifungals, and then your steroids. So again, for that, for the seizures, obviously, for prevention of losing that hearing. Bed rest fluids, you want to give possibly acetaminophen if they have a fever. You want to keep that fever at bay. But you want to watch, too, any side effects. So a lot of antibiotic treatment and things like that can cause diarrhea, stomach cramping. So those are things we want to educate our patients on. So I did give you all a break, but y'all got out early. So do you guys have any questions about any of this?
Repeat what you said about the next test.
What's going to be on it?
Yeah.
It'll be today's content, Wednesday's content. Mobility is next Monday. HIV is Wednesday. And sensory is the following Monday. So all of that will be on the next day.
That was a lot.
Yeah, intracranial regulations Wednesday, mobility is Monday, HIV is Wednesday, and then sensory is the following Monday.
And then the test is on
Jesus.
Wednesday.
Can we have like 100 questions?
Right?
You guys are more than welcome to come by and review your test. I highly recommend that because if you don't know where you went wrong, you want to come see, so you
I
don't.
do, though. And it's because I changed my information answers.